Let us proceed with our concluding session. Dr. Supriya Srivastava, Faculty of Biotechnology, please introduce our honored guest speaker.
Good evening to respected speaker, Dr. Israrul Haq Ansari, and good morning to all the respected dignitaries present, my colleagues and dear students. It is with great pleasure that I welcome Dr. Ansari. Dr. Ansari is presently working as a senior clinical trials scientist at University of Wisconsin, Madison, USA. He has completed his PhD from All India Institute of Medical Sciences, New Delhi. He was UGC CSIR scholarship recipient during his doctoral program. He has done MS in clinical research from Ohio State University, Columbus, USA. He is certified USA Regulatory Affairs professional. As a microbiologist, he has authored several research articles, chapters in books, and has a couple of research patents to his credit. He lives in Wisconsin, USA, with his wife and 2 children. His favorite pastime are fishing and visiting different US national parks with his family. Welcome, Dr. Ansari.
Thank you all very much. Thank you everyone for joining today's concluding seminar. Thank you all the organizers for putting this wonderful. I attended Dr. Ajit Bharti's seminar. That was wonderful. So thank you everyone again, and thanks for Dr. Srivastava. As Dr. Nehar mentioned, we did biotechnology, MSc biotechnology together, and I must say, thanks to social media that we got connected again. So I will start here. Let me share my slides. Can you see my slides?
No, it's not visible.
Can you see now?
Yeah, visible now.
Okay. All right. Thank you again, everyone, for today's last concluding seminar. As the Dr. Srivastava introduced me. Can you all hear me correctly?
Yeah.
All right. So, University of Wisconsin is fairly a large university, with almost 48,000 students, and about 15,000 faculty and staff. To its credit, including the one Hargobind Khurana that we all know. So today's topic, vaccine, where we'll be discussing what types of vaccine, what are the ingredients. Second section is efficacy, and we'll define the differences between the two. I just put together a small calculation kind of numbers, so And lastly, I'll be presenting the regulatory mechanism for drugs and the vaccine, which is very similar, and what are the approval mechanisms. So the word vaccine, or the term vaccine, was devised by Edward Jenner. This is a classical kind of textbook language. Who developed the concept of vaccines? First vaccine to denote cowpox. Obviously, the term vaccine is derived from the smallpox. He clearly explained everything in one of the paper titled Inquiry into the Variolous Vaccine, known as cowpox. In 1981, Louis Pasteur, to honor his legacy, that the term vaccine should be extended. Preparations were protective inoculation. So from then onwards, obviously we use vaccine, and that goes back to the 1798 to honor Edward Jenner. So let's go to the definition of the vaccine. Standard definition put together by the U.S. Center product that stimulates a person's immune system to produce immunity to a specific disease, protecting the person from that disease. They are usually administered through the injections, but latest technology also allows us to gold particles or other. As per the World Health Organization, there are about 25 vaccines available these days. Has a very wide reach. For example, it protects individuals, communities, and the entire population. Just citing one example for the measles vaccine from year 2000 to 2017, vaccination has reduced the death rate by almost 21 million. And when it comes to the economic value, every dollar spent on yields about $44 in the economic benefits. So we will be now switching gears a little bit to what type of vaccines are available, how they are made. So the first one I have listed is inactivated vaccines. So as the name indicates, it is activated form of a pathogen. So inactivation generally happens or generally is carried out via UV irradiation or chemical. That could be simply glutaraldehyde or formaldehyde. It usually does not provide immunity that's as strong as the live vaccine. So to boost the immunity, one has to take many dosage over the time. And some of the examples are like hepatitis A virus, influenza, polio, and rabies virus. The second form of the type of the vaccine is the live attenuated. Again, as the name indicates, is the weakened form of the pathogen. So that it doesn't cause a severe disease, but it's still active, it replicates inside the system and produces all the necessary component of the virus. Because of the similarity with the natural infection, it creates a long, lasting, and a very strong immune response. So if it creates a long-lasting and a strong immune response, one has to take only 1 or 2 doses, and it will be good for the lifetime. Again, since these are live pathogens, the problem is we need to avoid vaccinating the people, those who have a weak immune system or with the organ transplant. Otherwise, it will go out of control. Again, the examples are measles, mumps, rubella, rotavirus, smallpox, and yellow fever. The Next is subunit recombinant polysaccharide and conjugate vaccines. These type of vaccines are a specific part of the pathogen, so obviously they are very, very immunogenic. This could involve either part of the protein, sugar on the molecule, or the capsid. Again, it provides a very strong immune response because it's part of the microorganism. And the advantage is it can be administered into people, those who are immunocompromised or having an organ transplant. So we don't have to kind of have a real concern about here. The limitation is again includes booster shot. Examples are hepatitis B virus, human papilloma virus, whooping cough, shingles, and meningitis. Toxoid vaccines it's like an indirect form where pathogen creates a microenvironment of toxin where it grows. So the idea is to create a vaccine against the toxin so the microbe cannot grow in. Similar to other vaccine, it also requires a booster shot. Examples are diphtheria and tetanus toxin. Next set of these technologies are fairly new. They have been recently used in some of the vaccine preparations. So the viral vector vaccines, it utilizes part of the vector or modified form of the vaccine. Modified form of the virus, where we insert the gene of interest, what we are thinking to express inside the system. One such virus where modification has been carried out very successfully is the adenovirus. And recently it has been also used to produce COVID-19 vaccine. Some of the examples I have cited here, the manufacturers from Oxford, AstraZeneca have used it, Sputnik has used it, Johnson & Johnson is used. Similar technology has also been used to produce Zika virus, but in this case, the virus system used is vesicular stomatitis virus. And the most recent and very novel technology is using an mRNA technology. So the idea is you provide the mRNA, encapsulate it into the nanoparticles using either lipid or the other. And once it gets into the system, it will be directly translated. This technology was developed by two manufacturers, Pfizer BioNTech and Moderna. Lately, DNA vaccines have been also in usage. But the disadvantage with the DNA vaccines are the expression levels are not very high compared to these two. Viral vectors and mRNA vaccines they produce a really high amount of the protein when injected into the system. So let's move on to what actually is in the vaccine. When you take the injection or when the nurse injects into your arm, there are basically three components divided into main ingredient. What is the protein or the component of the pathogen. That is the antigen. It could be live attenuated, it can be inactivated, or part of the microbe, as we discussed recently. Additional components include, obviously, either a saline or albumin, BSA, or phenylglycine. Sometimes they also supplement with the adjuvants to help stimulate a better immune response. Some other salts are also included. The other trace materials are left during the preparations. Could be formaldehyde, as I mentioned, for the inactivation of the microbe. They use either formaldehyde or glutaraldehyde. So that traces are left in the vaccine preps. Other components could be thimerosal or antibiotics so that they can prevent the growth of the bacteria. So just want to have a kind of clarification. The drugs are very different from the vaccine. So we should not get confused between the two. We are talking vaccines, that's preventive, while the drugs, as per the US definition, it's a component or article intended for the use in the diagnosis, cure, mitigation, treatment, or prevention of the disease. But as per the European definition, it's very simple, which is a chemical, herbal, or biological product used to diagnose, cure, treat, or prevent disease. So clearly there is a definition. Clearly there is a difference between the two, vaccine and this. So just wanted to make a clarification. So since there are so many viruses on the planet, there has to be some kind of classification or categorization to put them together. And as the saying goes, there are more number of viruses than the stars. So general formula to classify the viruses are based on the nucleic acid component, like whether the RNA has the DNA component or the RNA component. So I have just put here for the RNA. So we'll ignore the DNA part, which again has millions of members. So the RNA viruses again will be divided into two components. First one is the single-stranded RNA or double-stranded RNA. Again, single-stranded RNA is comprised of two sections. One is positive-stranded RNA, and the other one is negative-stranded RNA. Again, it's divided into two groups: non-enveloped and enveloped. Same thing here. Envelope, non-envelope. So if you go down here, you can see coronavirus sitting here in the envelope, having a positive stranded RNA, single stranded RNA, and then it's an RNA virus. Again, if we have to go for the other viruses, so then it will be, for example, it's Scalesi, it's a non-envelope, positive strand, single stranded, and the RNA virus. So virus classification is generally based on nucleic acid component, followed by polarity of the strand, and then whether it's enveloped or non-enveloped. So this is the general schematic of the genome organization, if you see here on the bottom, and pictorial representation of the virus. So if you see here, the genome of the virus is approximately 30 kb long. It's a big RNA genome for the RNA viruses. About 3/4 of the genome is comprised of non-structural protein, which is called ORF1ab, which is further cleaved. You see these dotted lines into several proteins, PL protease, 3CL protease, RNA-dependent RNA polymerase, helicase, and exon nuclease. So these two are very critical, RNA-dependent and RNA polymerase and helicase protein. They help replicate the virus inside the cell. So once they help replicate the virus inside the cell, obviously more and more RNA will be made, and the nested sets of RNA will be made here. They will be translated and make the structural protein. These are structural proteins listed here. Obviously, many of you know a spike protein against which the vaccine is basically, is being made. Membrane protein, envelope protein, and nucleic acid. Nucleic acid also is very critical because it shields the RNA inside the virion, so the RNA doesn't get degraded. So the next slide is, I'm going to say, is general virus replication, and it kind of holds true for most of the RNA, positive stranded RNA viruses. So upon entry, you can see it's the uncoating happens, the RNA becomes naked, and then using the cellular machinery, it gets translated. You remember I said translation of the ORF1a happens. These are further cleaved by the proteases, and RNA-dependent RNA polymerases and helicase becomes active. These two proteins help make the negative sense of the genome, as it is listed here. And the negative sense, or the intermediate of the replication, you can call it, it makes several nested sets of RNA. Those express or those make structural protein. Again, from the negative sense RNA, it also produces a positive sense, which is exactly equal to the, or exactly similar to the viral RNA. So upon expression and further replication and making more copies of the sense RNA, the RNA gets shielded by the nucleocapsid protein. All the components go through the ER, Golgi, and then packaging happens, and egress, virus egresses outside the cell to infect further new cells. So that's the general replication strategy. So what scientists have done, if you see carefully here, for example, for example, if you see the spike protein RNA, so it's comprised of 5' cap structure, untranslated region, coding region in between, again untranslated region, and a poly A tail. So scientists, what they have done, they just exactly synthesize the same thing. They put a 5' cap at the 5', untranslated region, signal peptide, gene of interest here, untranslated region, and poly A tail here. And gene of interest can be anything, but in this case, it's a spike protein of the coronavirus. And then once you put this thing inside the cell, it will translate and express the protein of interest. The advantage here is the mRNA half-life, and it's well proved that with the poly A tail, it's about 10 hours. That's more than enough for the translation inside the cell. And studies had confirmed also that without the poly A tail, the mRNA lives only up to 30 minutes. So they were kind of confirmed. They were kind of, they knew that the RNA is going to stay a lot longer inside the cell. And once you provide all the necessary components like 5' cap, the cellular machinery will latch on, and then it will translate the RNA into the protein. On the other hand, adenovirus construct, they were modified, and these are viruses very common in the human and animals. They produce kind of symptoms like pink eye, common cold, sore throat. But they were modified in such a way that it cannot replicate inside the cell. And once they cannot replicate the cells, since these are double-stranded DNA viruses, it cannot integrate into your DNA. And obviously, it cannot cause disease. This is a simple schematic where generally the manipulations happen. They remove the E1 region of the adenovirus, and then they insert the gene of interest with the expression cassette. So once it goes inside the cell, proteins are transcribed and then translated, but the entire DNA does not replicate. So once these DNA version, or if you will, the modified version of the DNA virus, or the mRNA construct are made, they can be either injected or they go through liposome-mediated entry too. So once it is injected, the ribosome recognizes the 5' cap structure in this part. In this one, first transcription happens, and then the mRNA goes into the translation. Once the translation part happens, the proteins are expressed, and the APC antigen processing cells recognize these proteins and sends it to MHC1 and MHC2 class, and then response happens. So this is so far the general strategy for the vaccines what people have been making for these COVID-19 recently. General viral infection and antibody response happens. This is a kind of a schematic. I put it to make it easy to understand. When the virus infection happens, the viral RNA, obviously, and the antigen or the viral protein expresses inside the cell. And we can detect the RNA or the antigen up to 10 to 12 days. After that, it should subside because the IgM response kicks in and the IgM to IgG class switch happens. But in case of vaccination, we provide generally the antigen directly. So the antigen is injected. Obviously, there is no RNA detection, but a similar pattern, IgM should be kind of induced, and a class switch should happen, IgG. Again, as we discussed, since we are providing only the component of the virus, a booster dose generally is required by the day 28 to 30. Okay, so far, and now I'll just put kind of a couple of examples in the Indian context. What are the vaccines there? So in Indian context, obviously there are several vaccines, but the first couple of vaccines which were made in India were Covaxin. That's an inactivated version of the COVID-19. The chemical here used is the beta propiolactone instead of formaldehyde or glutaraldehyde. This was developed by Bharat Biotech in collaboration with the Indian Council of Medical ICMR. It has a variable efficacy. So against mild and moderate, 78%. Best efficacy against the infection already happened, and then asymptomatic 70. So overall, they have calculated about 77.8%. The next vaccine is a Covishield, which is developed by AstraZeneca and Oxford. This is again adenovirus-based vector, but if you notice, CH is put in front of this, indicating that it's a chimpanzee-based adenovirus. If you remember, I told you that I mentioned that adenoviruses are very common. It infects human, animal, birds, everything. So this adenovirus is derived from the chimpanzee's origin. And this is produced by Serum Institute of India. All right, so we will switch gears to vaccine efficacy and effectiveness. So does anyone have any question? We can, Can you all hear me?
Yes, sir. You are audible, sir.
Okay, great. All right. So if there is no question or concern, we'll be moving on. So let's distinguish between the efficacy and effectiveness. So efficacy is generally calculated or referred in the randomized clinical trial. So randomized clinical trial where the subjects are recruited, divided into two groups. First one is placebo, and the second one you can name as a vaccinated group or vaccine group. But the subjects do not know in what group they have been assigned to. So one group obviously gets either saline solution or dextrose. Second one or the vaccine group gets the vaccine. So in those, efficacy is calculated. Obviously, higher efficacy means fewer people will be getting sick. But the same efficacy, if you extrapolate to the general population or the bigger or larger population, then it becomes effectiveness, that how effective the vaccine is. Although in most of the clinical trials, we try to include a wide range of people to make a general representation that include wide range of age, younger to older, both the sexes, all the ethnicities, and even including the other medical conditions, so that it represents the wide variety of the people when it goes into the real world. So I have put together some numbers just to show how the vaccine efficacy is calculated. As I said, in randomized clinical trial, at least two groups, a placebo, where you do not administer the vaccine, and in the vaccine. And again, subjects are not given a choice. Rather, we just assign them. They do not have the information whether they have been getting the vaccine or they are not. I just put random numbers, for example, 10,000 people in both the groups, number of infected. Again, these are all imaginary numbers. For example, in placebo group, 150 got infected, and in vaccine group, only 5. So the infection risk becomes 1.5% in the placebo group, and vaccine in the infection risk in the vaccine group becomes 0.05. These are just relative to US, thinking 328 million population. You can always change the numbers as per Indian population or any other country's population. So first we have to get the difference of the risk between the two groups, and then divide it with the placebo group. So 1.45 over 1.5, that gives a 96.66. And again, bigger the number, that means less infection in the vaccine group. Meaning this one, the vaccine lowered the risk of getting sick by 96.66%. Or in a vaccinated population, 96.66% fewer people will get sick with the virus. So that's simply kind of, very easy. Students can do it as per their wish. Some of the common vaccines which are kind of, I have listed here. There are many, but just I picked up 4 or 5 to show what are their efficacy. Obviously, Mrna and Pfizer, they are on the top with 94 to 95%. The others, which are either killed viral particles or modified adenoviral vector vaccine, they are in the range of 70 to 80. But there is a logistic issue when it comes to kind of, shipping these vaccines. These bottom 4 have the upper hand because not everybody has the access to minus 80 or minus 70 degrees centigrade refrigeration and shipping module. So these are limited to certain areas. Not everybody can get it, but these bottom 4 are pretty much kind of, shipped everywhere in the world. But the other concern, obviously, these numbers will be changing. What I'm going to tell now, but when I picked up these numbers, you see from the clinicaltrial.gov number website, I picked up these numbers. So for Moderna, participants were almost 30,000, for Pfizer 43. So the confidence level for efficacy is really, really high. As compared to Covaxin, only 755 participants. That's not even close to phase 2 trial. I will go into the detail when I go to clinical trials of phase 1, 2, 3, and how many patients are required in each phase. So although they say 81%, but 755 participants are way too less. And that was the main concern in the early, when these vaccine started in the market. People were always kind of, a little bit hesitant that there is not enough number of participants as compared to Moderna and Pfizer. Okay, so these are some of the fun questions, you will get to hear either in the social media or WhatsApp group, whatever, does COVID vaccine contain a microchip? Does COVID vaccine contain a fetal tissue? Will it change your DNA? Can it cause infertility? And if flu vaccine can work. So answer for all these, is obviously no. All right. So any question, concern before we move into kind of different territory here, the regulatory aspect.
Students, you can post your question in chat box also, or you can directly answer.
Yeah, that's a good suggestion. Yeah, if anyone has any question, please write it in the chat box, and we can discuss either during the talk or at the end of the talk. Okay, great. Thank you again. And then we will be moving to regulatory aspect, how the drugs or the vaccines are authorized and how it comes to the market. So in US, FDA, which is Food and Drug Administration, is a federal agency that oversees all of the medical products, prescription drugs, medical devices, even export of all the medical and consumption of food, tobacco, you name it. In summary, FDA regulates almost 20% of the consumer spending. It regulates 75% of the US food supply. It has 19,000 prescription drugs approval, you name it. And even as little as remote control or cell phones, they are all regulated by FDA. And these are the budgets allocations you can see last year, human drug, which has almost chunk of, 1/3 of the total budget. Biologics, you can see 7.1, where vaccine comes in, or the other antibodies which are used for immunotherapy, they come under the biologics. It has a vast, number of organizations within the FDA. At the bottom, you can see all these centers which are kind of responsible for the evaluation of the drug or biologics. I have listed here, I have just indicated here two critical centers, Center for Biologic Evaluations. This one does the evaluation of all the monoclonal antibodies, immunotherapy products, and the vaccine. And Office of Regulatory Affairs obviously oversees all these centers, what are their benefits and risk ratio. So FDA and Regulatory Affairs, as I said, Regulatory Affairs oversees almost everything, and it's considered eyes and ears. And it's the lead office for all the agency field activities. It inspects all the products which are manufactured, which are analyzed, and reviews imported products offered which are coming into the USA. As I said before, this evaluates the benefits versus risk. So what are the processes of drug or vaccine approvals? So in a simplest form, once the clinical trials are over, which is preclinical, phase 1, 2, 3, you send the data to the FDA by filing an NDA, which is New Drug Application, or BLA, Biologic Application. So after the applications are submitted with all the data, FDA reviews it, and if it finds satisfactory, obviously you get the approval, and then packaging and labeling starts after that. So, but there are some other speed kind of processes to up the market approval, and some of those are either you designate your drug into certain class, for example, orphan drug, which is only if you claim that the drug only is going to treat less than 200,000 population, 200,000 people of the population. Fast track designation, there are breakthrough therapy designation, and obviously there are some incentives. If you say that you are not going to make more money, then they will kind of consider it. So under the fast track, and there is another approval method which I'm going to discuss pretty soon. The fast track distinguishes itself from that it has to have a kind of serious or life-threatening conditions and not treated by available therapy. So that's the distinction between fast track and then the other method which I'm going to tell now. So that means under the fast track designation there is already existing therapy option, and if the therapy what you are proposing is better than the existing one, then they will consider, and then they will again see the benefits versus risk ratio, and they will respond in 60 days. But the important one, which COVID vaccine manufacturers were using, is emergency use authorization. And under this clause, if the situation is considered as a public health emergency, which in case of COVID-19, it was declared by WHO as a pandemic. So manufacturers, got this, and they utilize that it has been a public health emergency, so it should be considered emergency use authorization. Another criteria to have the emergency use authorization was another use of this one is once it is authorized without any approval of the FDA, they will just say go ahead and do it. So without even approval of the FDA, you can start selling the product in the market, which is very, very rare, because without the FDA approval, you just cannot sell anything. So, there are no adequate approved or available alternatives, and that is the case in the COVID-19, because it was a new virus, it was a life-threatening, and was considered public health emergencies. But for doing that, obviously, manufacturers need to consult with the FDA, and it's very simple, kind of, you consult the FDA, you provide the reasoning, they will let you do it. So once submitted, FDA will evaluate within a week, actually, and then they will let you produce the product. In both the cases, Moderna and Pfizer, they chose as a rolling data providing mechanism, as meaning that as the data keeps coming for them, like within a week, for example, 1,000 subjects were enrolled. In the next week, another 1,000. So they keep providing on the weekly basis data to the FDA on the rolling mechanism. And obviously they got the emergency use authorization. So if you go back to the slide I put before, recently Pfizer put formal authorization from the FDA. And FDA, obviously, they look at the number of participants, they look at the efficacy, and they look at the benefits and the risk ratio. Benefits are way far better because there is no side effect, basically, except a kind of site of injection where some itching, pain, some nausea, some headache, very mild fever. But benefits are amazing, 95% in those times. With the new variants coming, obviously the efficacy rate is going to be changed. And that goes back to the property of the virus, because the RNA-dependent RNA polymerase of the virus is sloppy, it makes mistakes, and mutations are bound to happen. So the mutations will keep coming. Obviously, the problem with the efficacy rate, it might go down. So the recently approved vaccine from the Pfizer has been named Comirnaty, and that was approved on August 23rd of this year. We just came to know that Moderna has also filed a formal approval process. on the same day when Comirnaty was approved. So it might take few days, few weeks maybe to get the approval. Similar to FDA, India has also a counterpart, Central Drug Standard Control Organization, which is equivalent to the USA FDA. Also responsible for regulating and manufacture approval of the sale of medical devices and drugs in India. It regulates clinical trials and provides expert advice on the health issues. Again, it also enforces Drug and Cosmetic Act. So as I was saying before, what are the phases of the drug trial or vaccine? So let's see for the drug, maybe for vaccine, it's a little bit different because we will not start with the, so many compounds. But in the drug preclinical phase, it starts with almost 10,000 compounds where, studies goes in the tissue culture system and the animal system. You screen some, you found some, then you go to phase 1. And phase 1 is mostly the safety, like whatever the dose escalation people are doing or the clinicians are doing. They will try to find out how much tolerable dose is in a healthy individual. So you see the subject about 200 subjects are given only the drug to determine the dosage. Then they move to phase 2, where they recruit almost 100 to 500 subjects. And these subjects will be with the disease condition. So they will have a prior disease. They will be administered with the drug, what they found here as a safe to be administered. And then they will calculate the efficacy. So how many subjects with the disease feel better or cured, or how many did not. Again, they move to the phase 3 clinical trial, where more than 1,000 patients are recruited. And also it includes multi-center, and it's not limited to one clinic or one hospital. At different places within the country, maybe even international. So more than 1,000 patients at multi-center. Again, they calculate the efficacy using the similar dosage. And they randomize all these clinical trials. So we have one group does not receive the drug and the other group does receive the drug. Once you find your data convincing, then you file the FDA approval application. And that's where you file the NDA, which is New Drug Application. FDA kind of reviews the data and moves on. If they approve, you are good to go. If they find some error, or if they are not satisfied, you go back to the drawing board and fix it again. And if you see here, I just put a timeline here. So preclinical timeline is almost 3 to 4 years. Phase 1, 2 to 3 years. Phase 2 again, 2 to 3, and phase 3 again. So if you add up all these, one drug basically from screening to the final approval comes down to almost 10 to 12 years. But in case of vaccine, obviously you cannot start with so many compounds. A general funnel system I have just put it here, where you start with the kind of in silico 10,000, for example, 10,000 compound. In the preclinical development process, you select about 250. In the clinical phase, you come up with only 5. Then you start determining the safety and effectiveness, long-term safety, and regulatory approval. Finally, lets you just one compound, because all 5 may not be kind of beneficial. Some will be having more risk, others may be having milder. So from 10,000 compounds, you end up with the one compound. Again, the vaccine is a different story, but you still have to go to preclinical phase and clinical phase in the vaccine too. So this is just a summary table. So far, FDA has approved almost 170 vaccines that treats about 25 plus diseases. The most recent one is, just got approved for the Pfizer BioNTech mRNA vaccine. So vaccine innovation has been, it goes back all the way to 1880 or 1890. For example, typhoid fever, it was identified, the pathogen, but it took a very longer. So as the technology progressed, understanding of the science progressed, it took a little less and less time. And if you see here, COVID vaccine, it just took less than a year. This is described here, vaccine in just 1 year. That's simply amazing. I mean, kind of scientists and all the authorities kind of put together, it's unbelievable. It's remarkable, and how it has moved from, simply genome sequencing of the virus to preclinical studies, moving into phase 1, 2 clinical trials to 3. Again, as I mentioned before, rolling submission, you said, so that you keep on submitting the data as you receive on weekly basis. And it was approved for emergency authorization use in December. So why regulation is really important? I mean, you have to have a benefit and risk ratio, because you just cannot approve it thinking that, there may not be any risk. Simply, every drug is a risk. That's how the regulators think. Every compound what you take in will have some kind of risk or associated with the risk. For example, I have listed here for the acetaminophen, which is simple paracetamol. Everyone takes it, everyone knows it. It reduces the fever, headache, muscle ache, you name it. Risks are liver toxicity, stomach pain, nausea, sometimes loss of appetite, dark urine, etc. So obviously, people feel better after the reduction of the fever or headache. So benefit in this case is way higher than the risk associated with the drug. And how the risk happens in this case, for example, I said acetaminophen, it gets metabolized in the liver by the cytochrome P450. It goes through the intermediate, produces an intermediate, and it's acetyl benzoquinone imine, which reacts with the side chain of the heat shock protein, and specifically cysteine, which is a covalent bond formation. So it's irreversible process. Once the product is formed, it cannot be broken down. This product is toxic, and especially toxic in the liver. But under the normal condition, when you are taken off from the drug, the concentration decreases, and also glutathione system, it detoxifies, and it gets excreted in the urine. But under the overdose conditions, this toxic product becomes a problem, and many people face liver failure. But under normal conditions, once you're off the drug, it gets secreted, and you go back to the normal. So in this case, clearly, benefits outweigh the risk. So the regulators want to see that benefits are really favoring for anything, either vaccine or drug or anything. In case of COVID vaccine, mRNA vaccine is just unbelievable. The risks are really almost none to zero, kind of. So I will stop here, and Thank you all very much. And I will take any question, concern. We can have open discussion, whatever you feel like. So.
Participants, you can interact with Dr. Ansari.
Yes, I'm here. Anyone, please feel free to ask any question. If you are not kind of, you can always email me if you have any question or concern. I'll be happy to answer any question.
Sir, could you explain the types of vaccine you showed in your slide, inactivated? That has a very important part in the syllabus. So you can just, if you can explain it once more, types of vaccine.
Okay. So let's see. All right. So the types I have listed here, 7 types. So the first one is inactivated. So you just purify the pathogen and inactivate either using the UV irradiation or gamma irradiation or chemicals. Chemicals generally include glutaraldehyde, formaldehyde, those kind of things. So you kind of, have the intact virion or a bacteria and you inject everything as such. So so the protein coating or the capsid on the virion or the polysaccharide basically are recognized by the immune system and the immune activation happens. In this case, obviously you need to inject again to provide a booster shot kind of. Under the live attenuated one is the same pathogen, but with the weakened form of it. So it will not create a disease pathology, but it will be replicating inside the cell. Yes, so it will produce the protein, it will produce the toxicity, it will produce the RNA and virus as a normal thing. So when the protein or peptides are produced inside the cell, again, the cell will look this as a foreign antigen and it start kind of reacting to it. It will kind of go through the proteasomal degradation and then present it to the APC and then MHC 1 and 2 class will be activated and immune response will be there. These form again includes measles, mumps, rubella, rotavirus, smallpox, and yellow fever. By the way, rotavirus vaccine from India is a very big hit here in the US too. The third form I have listed is a subunit, either recombinant, polysaccharide, and conjugate. Subunit means, just part of the virion or the pathogen. It's not the entire virus or the bacteria. And that's what happens with the COVID vaccine because it's a subunit vaccine. It's not the entire virus because there are other structural components too. But it provides a very strong immune response because it's part of, and it's a small, it's exposed outside, and immune system recognizes it pretty well. Advantage is it can also be given in the immunocompromised because it's not attenuated form, which keeps replicating inside the cell. So immunocompromised and organ transplant patient can also have it. Limitation is, again, you need to have a booster shot. Hepatitis B, human papilloma, whooping cough, shingles, and meningitis. Toxoid, it's an indirect vaccination strategy where pathogen creates a toxin. So you need to get rid of the toxin so the pathogen cannot grow. That's an indirect kind of, is targeted against the toxin instead of the microbe. other vaccine, similar to other vaccine, is also requires a booster shot. Diphtheria, tetanus toxin. The viral vectors, as I mentioned, people use adenovirus, where they alter or remove part of the genome and then insert with the gene of interest. Several manufacturers, Oxford, Zeneca, Sputnik, and Johnson & Johnson, they all use the adenovirus, where they have inserted the spike protein from the COVID-19, and they found good efficacy. The other system people also use in the vesicular stomatitis virus, where they have replaced the viral glycoprotein with the Zika glycoprotein, and this vaccine works pretty well. But unfortunately, VSV system was used from Merck to produce the COVID-19 vaccine, where they replaced the VSV glycoprotein with the COVID-19 spike protein. They were able to recover the virus, and it was able to kind of generate some immune response, but it was not good enough. So the technology is there, but the concern may be sometime that it may work for the one virus and may not work for the other. And the simplest, the very good example is the VSV. It worked for the Zika virus. It did not work for the COVID vaccine. So they spent really quite a lot of money, but Merck did not get their product in the market. The mRNA vaccines are the novel ones. These are the recent technology where manufacturers or the scientists they just synthesize the mRNA, which is exactly similar to the viral produced mRNA. So it just gets inside the system or inside the cell and start translational procedure happens. Both Pfizer and Mrna were successful, and they led the vaccination strategy. DNA vaccines are coming up. Again, COVID-19 vaccine has been based on DNA model too, where they have cloned the spike protein expressed into the cell, and then obviously they can see. But the thing is, the expression level of the spike protein when they were using the DNA plasmid was not as robust as mRNA vaccine or the viral vector vaccine. So that were the different types of, and if you see here, so this was the mRNA vaccine, what they have. So they have made a very similar or exactly the same with the 5' cap structure followed by the untranslated region, a signal peptide, gene of interest, and that's where the COVID-19 spike protein is inserted here. Again, untranslated region followed by the poly-A tail. And this serves as a direct translational unit once it gets inside the cell. These are encapsulated with the lipid molecule. After its injection or delivery into the cell, it's taken up by the phagosomes, where uncoating happens, RNA gets out, translated, and then it's proteasomal degradation, and then presented to the antigen presenting cell, and then immune response happens.
Participants, you can post your questions. Dr. Swarnim, can we proceed with the vote of thanks? Madam?
Vote of thanks from Salini and Mundu.
Yes, our faculty. Yes.
Am I audible?
Yes, Shalini, you're audible.
Yes, you are.
Good morning, everyone, to the one and all present here. Honorable Speaker Dr. Israrul Hakansari, sir, respected Principal Dr. Shamsun Nihar ma'am, Ranchi Women's College, our coordinator Dr. Shalini Mehta, Dr. Swani, Zoology Department, our faculty members, and my dear participants. On behalf of Department of Biotechnology and Zoology, I'm Mrs. Shalini Jane Field, honored to get the opportunity to thank you all for your presence and contribution to make this webinar a great success. I extend my gratitude to our honorable speaker, Dr. Israrul Haq Ansari, sir, to take out time from his busy schedule to grace the event. Thank you, sir, for inspiring and increasing our knowledge on vaccines. As vaccines are now become a lifesaver for all of us, it is the biggest need of the current situation. Thank you, sir, once again for encouraging us with your words on this special day. I thanks to Dr. Samshuni Harmam, Principal Ranchi Women's College, for providing immense support to make this webinar successful. I extend my gratitude to the organizing team, Dr. Shalini and Dr. Swani, to organize a webinar even amidst pandemic. I congratulate all the participants for their active participation. Thank you, everyone, once again for making it a great success. Thank you all. Now, Sumati.
So there are a couple of questions. Can we discuss here or later? Is that
Yes,
okay?
sir. Kindly
Okay,
discuss.
sure. So
Please
yeah,
discuss.
please. So the first question is from Varsha Kumari. If mutation occurs in a spike protein of virus, then how effective will the mRNA vaccine is? So it all depends where the mutation happens. If it happens in the antibody and antigen binding zone, like the epitope you call it, if the mutation happens in the epitope, then it's a problem. Then the mRNA or any other vaccine, because the simplest form is we are trying to express the protein out of mRNA or the adenovirus, both the system. So the concern is if the mutation happens, if it happens and it falls into the epitope region, then the vaccine is going to be ineffective, and that's what happens in some of the mutation. People see it like in the earlier they call it like Indian variant, but now they changed it. So that's a good point. And second question is Kriti Kumari. Among the different type of vaccines, according to you, which type of vaccine is most effective in humans? Obviously, we are talking about the humans, but effectiveness actually varies, as I told you, because when the vaccine goes into the wider population in different ethnicities, it will start changing. For example, the Sino vaccine from China, in their efficacy, they claim it's 80%. But right now in Brazil, it's only 50%. So because of the change in the population, change in the other logistics and other health conditions, things change. But it should be close. If Chinese vaccine, if Sino vaccine is 80% in China, it should be close to 75 in other parts of the world. But somehow, it's not more than 50%. So far in Moderna and Pfizer vaccine, they have been showing consistently very high effective efficacy. Obviously, the neutralizing antibodies are short-lived, but they are still 95% for up to six months. Ayushi Arya, is COVID vaccine and Covishield vaccine mixing is safe? That's a good point. Yes, it is, in my view, because both are designed to express, or both are designed to provide the antigen in form of the spike protein. Covaxin obviously provides more protein because we are injecting the entire virus, but we are also providing the surface protein, which is a spike protein. So the antibody raised against the spike protein will kind of will be getting a boost when we will be injecting with the COVID shield. So in my view, it can be mixed and matched. It's not a big problem. Ritu Singh, people say that vaccines are linked to long-term health problems such as multiple sclerosis, diabetes, and autism. Is that true? It's not true so far because people have been vaccinated at least for 6 to 8 months. I got vaccination, my wife got it, and several others. The number you saw in those slides, 30,000, 40,000 in the early days. Right now it's into the millions, and almost 150 million to 160 million US population has been vaccinated. And there is no report of MS or diabetes and autism. It's all kind of theoretical. People kind of get mixed up with the ill-informed decisions and some kind of gossip, but the science is very clear, and there is no association with the MS and diabetes. It's not true. Imadri, can we use certain bacteria that can kill coronavirus? No, bacteria cannot kill any virus. It's the opposite, right? The virus kills the bacteria. Namita Kumari, why there is a need of second dose? Oh, that's a good point. So you remember in the types of vaccines we were discussing. So after the primary boost, IgM when switches to IgG, it declines. So decline happens about 28 to 30 days, and that's why the second dose is given after the 4th week, like a month or so. So that's because once a person develops a memory against that antigen, so memory cells kind of they need to be activated. So if you inject the antigen again, memory cells will be activated in a robust form, and then the antibody titer goes very high, and it lasts for longer, at least 6 to 8 months. It should be. And she is also asking, maybe we have to have third dose. That's quite possible because the antibodies look like at this stage that they are not staying for a long time. So there could be a possibility that we will be taking a third booster, which is already in discussion, and FDA has already kind of suggested. CDC is recommending. The US government is thinking of doing it, but obviously it has not been implemented yet. That's a good point. Is due to variation in virus strain or due to some other reason? Yeah, you can say the variation. Obviously, as I said, the RNA-dependent RNA polymerase is a sloppy enzyme. It incorporates lots of mutation, and unfortunately, some of the mutations are against the spike protein. So if the epitope is compromised, the antibody produced against the earlier version will not be recognizing or will not be neutralizing the newer mutant or the newer kind of incorporated mutations. So there is always a kind of a concern, and that's the reason the better we can kind of vaccinate the people early, the less chance of virus kind of to mutate in a general population. So the best is to get the vaccination early, stop the spread, and stop the further mutation in not only the spike but other parts of the genome too, because you never know if the mutation happens in any other part, like RNA-dependent RNA polymerase, for example, and then it will be super active enzyme, which may kind of cause another havoc, that virus will be growing so fast. So these are all hypothetical, but when things are kind of tricky, we have to take precaution and we have to go what the virus says at this moment. So these are all very good questions. Thank you all very much. I love talking to you guys. If you have any questions, please contact me. I'll be happy to answer it. Last question, if we take vaccine without taking any meal, what will happen? Oh, so vaccines are not kind of, like the medications. Medications you take orally, where you need to have plenty of food and other things, especially some antibiotics, because it will kill the bacterial flora in your intestine. And that's why they recommend, taking the meal. But in case of vaccine, it's not needed. All you need to be in a kind of, infection free. So that's why they call it. They used to ask you, do you have a fever? Do you have a cough? Those kind of things. So if you don't have those symptoms, you are good to go. But plenty of, hydration is needed, because the system kicks in and then your body starts working extra. So you need at least hydrated. You need to keep hydrated. You need to keep the energy level up to the level. So, just keep hydrated and you will be fine. Thank you all. Looks like these are all the questions so far. Okay.
So thank you, Israr, for
You're welcome.
sharing us such valuable time for the benefit of my students. So we'll look forward for more such informative lectures from you in the future also. So thank you very much once again.
Thank you all. Thank you all the organizers, and thank you again all the students participating. Good to have you again. Thank you very much. Have a good day.
Okay. Good night.
Thank you, sir, for your such an informative session. Thanks, everybody. Thanks, participants. We can now log out.